Hello, and welcome to another episode or series in our Ask the Experts. I'm so excited today. Our guest speaker that will be joining us. But first, before I introduce him, today is October 1st. It is the Pregnancy and Infant Loss Awareness Month. So I'm so excited. Our guest speaker is Dr. Rick Goldstein, who I've got to read his bio. It's totally amazing what he is doing as far as research into SIDS. And I think, when we're kickstarting this month, what a great way to start this month, but to have him speak about his research and some of the findings that he has come across. So, Rick, this is a long bio. So Dr. Rick Goldstein is a leader in research and care for families after the sudden, unexpected death of their children. His work investigates the etiologies of the mortality and its implications to a family in its aftermath, especially the impact of child loss and grief. He is the director of Robert's program on sudden unexpected death in pediatrics at Boston Children's Hospital, which pioneered a translational medical approach to sudden unexpected death in children as an undiagnosed disease, incorporating clinical care, counseling, research, and advocacy. Rick is also a palliative care pediatrician, where his work focuses on primary palliative care skills that can be used by all clinicians when caring for their seriously ill patients. He is an assistant professor of pediatrics at Harvard Medical School. He's also a member of our medical advisory committee, and he was just voted onto the board for the Society for the Study and Prevention of Perinatal and Infant Deaths. So welcome, Rick Goldstein, Dr. Rick Goldstein. Just reading this, I know are super busy. So really appreciate you taking time today to speak with us, especially on such a day today. And I just thought maybe we should just jump right in, because you said, and I know this will be interesting for some people, that SIDS is an undiagnosed illness.
Yeah, that's one of our central hypotheses. That's really one of the core things that we investigate in our research. So just to try to unpack that a little bit, I think most people would think that when they think of SIDS or they think of sudden unexpected deaths, they think of them in terms of sleep accidents. And for several reasons, I'm just like a later generation of people here at Harvard who have had some questions about that. And there's a long history of work in pathology and neuropathology that has found almost every time we've looked that among these children who are thought to have died for unexplainable reasons, we see traces of disease. But then there are two other things. So we fixate a lot and we think a lot about the fact that the babies are often discovered in the prone position, and that's really the basis of sleep advice, and I'm not here to question that at all. But we also notice that when older children die without explanation, they are predominantly, and they die in their sleep as well, they're predominantly found in the prone position. And people that have epilepsy, if you have epilepsy, you have a 24-fold increased chance of dying unexpectedly in your sleep, unprovoked, and they are also found prone. So that's piece number two that leads us to have some questions. And then the third thing is that when a lot of our confidence in the sleep advice has to do with the rates of decreases in mortality in SIDS, particularly in the early 1990s. And really, coming in from palliative care, I go throughout the hospital, and I would go to conferences in neonatology, and they would be talking about the fact that in neonatal diseases, there was a tremendous improvement in mortality in the NICUs between 1990 and 1994, and then it's plateaued out. And then I would go to other child health conferences, and we would see the same trends in older children. And that further supports the idea that there might be some basic ideas, basic causes that have more to do with medicine and less to do with an accident and preventing accidents in the sleep environment.
Mm-hmm.
So that fuels us. And then, when I was first in training, there were all these diseases that we didn't know about, and we would tell the parents, these are parents with living children that are very impaired. We'd say, well, we don't really know. It's not a questioning of how difficult your child's life is, but we don't really have an explanation. Come back next year and let's see what the field has developed. But with genomics, that's really changed a lot. And now we have this idea of approaching diseases that have defied diagnosis. And it relies on what we call deep phenotyping. So that's a very concentrated look at medical histories and family histories, very careful look at whatever physical evidence there might be in the patient, and in this case, in the child or infant. And then also to look at genomics and discoveries in genomics and see if these different bits of information can come together and reveal something about what's going on. And for living patients, the diagnostic rate for some of the premier programs is about 30%. So these are families and patients that have gone from doctor to doctor looking for an explanation. They end up at an undiagnosed disease program, and then with genetics and this deep phenotyping, they're able to make a diagnosis in about 30% of the time, which is, that's tremendous, right?
It's awesome. Yes.
But it's a technology that for many reasons hasn't been applied in kids, which is also an undiagnosed disease.
Mm-hmm.
Has maybe a little bit too easily been thought to be an asphyxiation accident.
Right.
So that's what we do. We've done work on the phenotyping side of things. So phenotyping is just the general characterization in medical terms of the presenting features of a patient. And so Dr. Hannah Kinney, who helped me found Robert's program, and who's sort of set the direction of what we do, she discovered that about 40% of children who die of SIDS have deficiencies of serotonin in their brain stems. And further work has gone on to show that low levels of serotonin in the brain stems of a child or in a mouse model lead to a failure to respond to these small little threats of asphyxiation. So if you're just breathing a little bit less oxygen and a little bit more carbon dioxide, your heart starts to go fast and your blood pressure might respond and you'll breathe in a different pattern. And when you lower the serotonin in experimental models, that disappears and they just lay there and they don't auto-resuscitate is what it's called.
Wow.
They don't rescue themselves.
Right.
So that's one chunk of our phenotyping. Another chunk of our phenotyping is that when we looked, this is research that began more with children over 1. There's something called sudden unexplained death in childhood. And we found that a surprising number of those children had histories of febrile seizures. These are innocent seizures that occur in the setting of a high fever, and they usually go away after a few years, and pediatricians are generally very reassuring about it. But it made us look a little bit more closely at features of epilepsy that we might discover. And to get to the punchline, about 48% of the children that we looked in the brains of who died of SUDC had evidence in their hippocampus of the brain of classic markings of seizure activity and classic markings of epilepsy. And we find that in about 40% of SIDS children as well.
Wow.
So So that's what's going on the phenotyping side, and then we have been applying our genetics work. And we're not the only people that do it. So there's a group at the Mayo Clinic, and they've reported they're mostly focused on cardiac issues. We think cardiac is probably less important than brain-related features, but they find that in about 4% of children who have died from SIDS that you can find cardiac rhythm or cardiac diseases in the muscles. They can find genes that are related to that. And we know that about 2% of SIDS involves metabolic diseases and syndromes that have not been further characterized. And the children don't, it's only after their death that we make this diagnosis. And we're just in the process of presenting our data on this. So I'm not completely at liberty, but I think when you take a more comprehensive view and you say, yes, some of this is heart disease, but everyone who dies, their heart stops, and let's broaden our idea and include of what's going on and include other things. We can almost double that. And then when we include brain features and consider that to be some part of the explanation, we probably have things to say to about 30% of the parents whose children come here.
Yeah.
70% we don't really have much to offer. But techniques are changing all the time. 30%, these are people, these are children who we didn't know anything about, some of whom have genetic findings that have implications for other children or for other family members.
Oh, for sure. Yeah. And I think just even 30% is a huge number for those those families that actually get peace of mind, or at least can say this is what happened versus, and I mean, that's a great number to have. And hopefully, through more testing, we'll.
Yeah. I also think that there are benefits, when a baby dies from SIDS, they're not considered properly a patient. And we know that, we're talking about child loss, and so we're talking about stillbirths as well. These are disenfranchised deaths. They're not really, they're not afforded the same status and the same attention that other deaths are in society for whatever reason. And we have found with the families that have come through our program that just having an exhaustive approach, just looking as hard as we can, is itself useful, therapeutic.
Oh, I absolutely agree. I mean, and I think, because I know you're in Boston and we're up here in Canada, and of course, I'm not aware of any organization that is doing this type of study. And you're right. Most families are left with unanswered questions, and even to have exhaustive tests done to the point where you can say, yes, this is this, or no, we don't know, still can give families peace of mind in the end. And if most families that have reached out to us, that's all they need is to have that peace of mind, right? And when you're left with unanswered questions, it weighs on you.
Yeah,
for sure. Now, if we had families here in Canada that wanted to participate in your studies or to send you samples, how could they do that? Or can they do that?
They can do that.
Okay.
So they can do it. All they need to do is, we'll provide the information of the email address and the website. Yeah. And they can reach out to us that way, and then we can advise them on what's involved in the evaluation.
Sure.
Not ideally, but the one very important part of our assessment is not just to do what's called a proband analysis. In other words, not just to look at the genetics of the child in isolation, but to look at both parents, both biological parents, in relationship to the child. And then we can say things like, here's a suspect gene that has a mutation in a bad place. And neither of you parents have it. This was a spontaneous mutation. And so all your other siblings, all the baby's other siblings, we don't have to worry about. Or we can say, and this has happened, here's a suspect gene. I know that you've been having fainting problems and you've seen a cardiologist and you have some abnormalities on your EKG. We wonder if you shouldn't get genetic testing. And in fact, your uncle that got a heart transplant and your two other aunts that had early cardiac deaths may have been related to that. So the implications of really trying to understand this within a family are, that it doesn't, we don't count on it being that important, but it is with some frequency very important.
For sure. Well, I think what we could do is maybe put a link on our website with more information. And certainly if families wanted, to, do some testing and we could probably put on this what they should be asking, when they're with their doctor or the coroner's office, what kind of samples, tissues, and things they should be saving. Is that fair enough?
We have an idealized inventory of samples.
Okay.
We need a source of DNA from the child, but also from the parents. We need both of those. I also want to say, in the way that all these things are, so once we get the samples, everything's free. The families, there's no additional cost to the families.
Okay.
And the reason for that is that families that have been through our program want it to be available to others, and they have their bake sales and their walkathons, and they make it so that we can respond to whoever has need. So as long as we can get the materials here, we can communicate. It's practicing without a license. If I find something and I tell them in Canada what to do, but sometimes we can rope in the family's doctor and they can facilitate that.
Oh, yeah.
So really it's almost all as available. The one thing that we can't do, and we're now that we're in COVID times, we're trying to think about this, but we generally have included group therapy support for the families as they're going through the process of figuring out what happened.
Right.
They're at an equal. They're on equal footings in terms of understanding and dealing with the shock of what's happened. And it's at an early enough time that there are a lot of very important basic things that we find people do better if they have help with, like you respond at the supermarket when somebody says, how many children do you have?
Yes.
What do you do for a birthday? Or, we have a session where people bring in pictures and mementos of their child. And they just talk to the other parents about who their child was, just so that they can do that out loud in public to people that they don't know so well.
Yeah.
And just learn those kind of basic skills that, fortunately, most people they don't even know that it's a problem.
Right.
But
well, I was just saying here with Baby's Breath, and then, the fundraising that we're doing, we do provide grief counseling, family grief counseling. So we have, again, because of COVID, luckily enough, this was all done by teleconference call. But now with Zoom and all of that, our grief counselors are able to have like one-on-one with a family. So we do a lot of fundraising to support this program. And this year we've seen a huge increase in families reaching out to speak to someone. And the whole point of the program is really just to get them the immediate help they need when it happens. And then eventually the goal is for them to find someone locally that they can speak to. And one thing that we are doing, so this might be a good segue, since I know, you've got a busy schedule, a busy day ahead of you, but on October 15th is our Wave of Light. And what we will be doing is what we call an angel roll call. So we're encouraging families to submit pictures of their babies with their name, and we will be doing a video. And we did this last year, and a lot of families, it was just so important that, their baby wasn't forgotten, that they saw their name. And, so last year we were able to come together. This year, this will all be done virtually.
Yeah.
And we'll be wrapping up the month with a brunch gala. So that will be done virtually as well. So, during these times, you got to do, you got to think creatively and outside the box.
Yeah.
But all the money that we raise this month will be going to our counseling. And we've just seen a huge increase this year in families reaching out. So I think we'll leave it there. Rick, thank you so much for joining us. We will, I'll connect with you later, and we'll get a link, put on our website so that families that are watching this, if they do want to get in touch with you, they'll be able to do so. So thank you so much today for joining us. I am so thrilled you are on our medical advisory committee. You are such a source of information and knowledge, and I can't wait for your paper to come out and read it. So thank you. And thank you to everyone that joined us today.